Well, welcome back, Dr. Schneider and Dr. Singh. I'm Larry Patterson with Eye Centers of Tennessee, and I want to thank you all for being here for another episode of the multi-part series, Improving the Continuum of Care. Now, previously, we talked about how total practice efficiency and an enhanced uh, experience for patients and providers can lead to better patient outcomes. And today, we're going to dive a little deeper into that and explore how you use the ZEISS retina workflow in your total practice. So I'll begin with Rishi. I'm going to ask you, tell us about your current workflow in your retina practice and how does that allow you to maintain a very high volume practice?
Yeah, Larry, we used to spend a lot of time asking for additional analyses from our photographers, different cuts of the OCT sometimes because we were looking at static images. And with Retina Workplace, we've been really able to use the entire cube in our workflow. We can look at any specific item. We can do RP analyses. We can do, change analyses ourselves at Retina Workplace. And additionally, we use it to track our injections. So one of the real advantages I think of Retina Workplace, which I think is an utilized feature, is the ability to track injections and intervals between the injections. And that's what I do a lot. I think when I teach trainees, a lot of times they'll come in and they'll say, "Oh, the patient's not getting any better," but they don't have the longevity of seeing that entirety of what the patient's gone through. So showing them on a graph the entire course of a patient is really helpful to understand the global view and really make a decision better, quicker, and more accurately in patients.
Eric?
Yeah, I mean, I agree with everything Rishi said, and I actually would double down on his comments about that sort of longitudinal analysis that Forum allows. I think I find that particularly helpful when I'm seeing my partner's patients. You're wondering why they're at a specific interval. It's very easy to use that tool. And quickly, click and drag different exam from, prior visits and see exactly what's been going on. So I think that's very helpful. I think, from an efficiency standpoint, certainly our practice is really focused on sort of, minimizing patient and doctor downtime and avoiding bottlenecking. And I think, just from a device standpoint, I think the speed of some of the ZEISS devices we have in our practice, the Cirrus 6000 and the Claris 700, I think that really is something that can help us cut down, on bottlenecking in imaging, which had been a big issue for us in the past. Around 9:30 or 10 o'clock, we have this glut of patients who are all waiting for images, and we're, as the doctors and the staff, waiting in the exam lanes with no patients to see. And so I think that's been a real boon for us. And I think not only the device is quick and effective to use, but they are easy to use. And so we're also able to sort of cross train staff. So if we need more imaging staff, we can send scribes back to do OCTs or even Claris photos, which I found again cuts down on sort of that bottlenecking issues. And the devices themselves also do great with undilated pupils, and so again we don't have to drop the patient and then send them to dilation after being checked in and then send back to imaging. We can send them right from check-in to imaging, and I think again another way that we can kind of improve throughput. And so I think there's a lot of different ways that we found that some of the imaging devices have really cut down on one of the pain points in our practice for sure.
Diving down specifically, what ZEISS products do you depend on, and how has that technology changed how you practice today compared to say 5 or 10 years ago? Rishi again.
Yeah, I think the big difference for us has been the utilization of OCT 5000 and eventually 6000. I think OCT 6000 has a significant number of advantages with regards to its protocols and what we're able to achieve, and the rapidity and speed and what we're able to do with it. So I'm excited by the new device and its future. But just I think the overall integration of data between the IOL Master 700 and then the other devices, the Atlas topographer, really convey a combined view. Larry, I'm a closet cataract surgeon. I'll admit that. I'll do a few cataract surgeries here and there. But, I think my cataract colleagues and I both appreciate when we have a universal single record to compare to and look at, because sometimes the cataract surgeon might be doing work on a patient and realize they have a macular pucker, or I'm doing work on a patient for retina and I realize I got to take out the cataract and I realize it's far more complicated than just a simple, lens surgery. There might be a toric involved. There might be other things involved. So thankfully, because it's a shared record, it helps us, kind of look at it together.
Eric?
Uh, yeah, with the Cirrus 6000, we maybe 2 or 3 years ago had upgraded most of our devices from the Cirrus 5000 to the 6000, and the speed difference was pretty incredible. And I had sort of mentioned that earlier. But along with faster acquisition, it's not just about cutting down on patient chair time, but also it allows you to do a lot more imaging. I think the image quality is much better because you're able to oversample a lot more. You can get a lot more B scans per second, which then allows for sort of denser imaging or oversampling. And that's also really increased our reliance on OCT angiography. And I think because it's faster, I think the image quality is better, and you can do a lot more sort of wider scans and more detailed scans, from an OCTA perspective with these faster devices. And I think that's really reduced our reliance on sort of traditional angiography, which again is another, time savings, but I think the patients appreciate it. It's non-invasive, and I think the image quality is great. We also have, integrated a lot of Claris 700s into our sort of equipment milieu, and I think those are great devices because this is actually something I remember I heard Roger Goldberg talk about once, but it talks about the forest and the trees, right? A lot of these wide field cameras are getting great wide field images, but the macular detail is pretty poor. What I like about the Claris is you get that sort of wide field perspective, but you can still drill down and zoom in and maintain that good macular quality. So especially at our satellite offices, you're able to have sort of one camera. In the past, I'd have a wide field sort of SLO camera, and you get a macular scan, a macular FA for macular degeneration like that. I felt that was limited, whereas the Claris, you really get that detail. So I think those two devices in particular have really changed how we've practiced quite a bit.
And I'll add, Rishi, I'm a closet retina surgeon. Well, I don't actually do any retina surgery per se, and I'm about an hour and a half from Eric, and we share patients a whole lot. But we're in a rural area. There's no retina surgeon anywhere near us, and we do a lot of we just were forced into it years ago. A lot of injection work, but Eric, for example, will do say a macular hole repair or epiretinal membrane. Once they're out of the immediate post-op period, he could feel very comfortable sending them back to us because we have all the ZEISS, we have the Forum, we have the OCT, of course we have the cameras, IOL Masters and all that, and it actually makes it nice that he can know when he sends us his patients, we can actually follow their macula the same way he's following it, and while we can't fix problems in the macula surgically, if we see a problem, we know we can send them right back. So, how do you prepare your staff? This with some devices we all use, staff training is really complex and all that. How do you prepare your staff to have the tools and resources they need to really have that best patient experience, where the patient feels comfortable, they know what they do, and we know that they actually do know what they're doing?
Yeah, I'm happy to take that. So one of the things is we've actually used the ZEISS Academy as a way of extending some of our initial training of individuals so that they can really get a sense of how to start working with the devices and everything else. Obviously, it's a buddy system when we first start. There's always usually a person with that person. That's always the best because, even though ZEISS Academy is great, there's always a little nuances of like, hey, you know, for a EDI scan or for a particular type of scan we want to do, there might be a certain setting we need to get to or whatever that might not be as obvious to them. So some of that, and I think is helpful to do that, and at least initially. And then the lastly is just feedback. I think if you don't give good feedback on, say, for example, an error or a situation, the provider, we typically will be involved. We'll say, hey, we really wanted to take this picture of this particular area, and we missed because we were off of the mark, for example, in a macular scan or from some other scan. Or if there was too much motion artifact, we teach about that. That's another thing that we have to, kind of teach people about. And so that's an opportunity for us to provide feedback to them to say there's things we could do better with this.
Eric?
Yeah, we found that the ZEISS support team is great. Every time we get a new device, we have someone in the office, for several days afterwards, sort of working with the staff. And so certainly I think they can certainly train up sort of our super users, if you will. And then, as Rishi said, we kind of filter that training down through sort of peer-to-peer, training. Certainly when we're onboarding new people, whether they're, solely imaging staff or even scribes, we do have a fairly structured sort of training program, and that does include, time with more experienced photographers. But at the end of the day, I think these ZEISS devices are quite easy to use. I remember being a fellow, maybe not as long ago as Rishi, but a while ago, and we used to try and get OCTs on call for patients occasionally if there's some mystery diagnosis, and certain devices I just wasn't able to use to get an OCT no matter how hard I tried. Again, I'm not someone who took OCTs regularly, but the ZEISS, you could just kind of turn it on and sort of plug and play, and so I think that's a big factor. Certainly we do feel training is important, and we want to be able to do not just standard but sort of advanced imaging, as Rishi was saying, in terms of getting peripheral OCTs or OCT angiography and those sorts of things. But at the end of the day, these devices kind of are low impact in terms of ramp up time or onboarding time for new staff, and so I think that's a real benefit of our experience with ZEISS thus far.
For those of us who are in referral practices, I'm going to kind of go 90 degrees in a different direction. A lot of the lifeblood depends on referrals, getting outside ophthalmologists, outside optometrists to refer patients to you. And how do you guys go about fostering or nurturing those relationships, Rishi?
Yeah, I think for that we try to first and foremost give them the records. So actually, what I do before patients leave me for Cleveland for Florida or vice versa nowadays, I actually print the entire graph for them to see. Where the patient's been, from what in the workplace. I can put the 3-up view and actually print out the last 3 OCTs in a row. I can provide them that information in hand so that they walk into the office, and they might walk to Larry's office or Eric's office, and then where their baseline is. What fluid they had. What their overall status was, and that is a very powerful tool. Beyond the idea that I think that in the future, maybe near down the road, maybe we will have some universal shared record amongst practitioners that we can give out a code to kind of go there, but we're not there yet. But in the absence of that, I think you can provide them really, really good overview information with ZEISS Retina Workplace, which I give to people on their way out to hand to the next physician who might be taking care of them.
I think that's great. Eric?
Yeah, I agree with Rishi. I think making sure that the referring doctor is plugged into what's going on. Whether you're referring them back to them or even if you're kind of continuing ongoing care. I think that the referring doctor certainly wants to be kept informed as to what's going on with their patient. It's a frustration, I think, for referring doctors if they send a patient to a practice and then hear nothing about them for a year, and then suddenly the patient shows back up in their office and wonders why you, as a referring doctor, doesn't know what's going on, and I feel like it reflects poorly on the referring doctor, and really it should probably reflect poorly on the doctor who's not keeping that doctor updated. And so I think we're very careful about including timely letters to keep the referring doctor updated. Certainly our major referrers have our cell phones and emails, and we do dedicate a lot of staff time. We have 2 full-time employees who do sort of practice outreach. Really it's about availability and then high quality care. I think that the availability is just making sure that we're reachable either by our front office staff or just personally on cell phones. But also I think that high quality care comes down to not only providing high quality care, but are we keeping that the referring doctor informed as to what we're doing. And I think Rishi hit it on the head. They want to see that progress, and so if we can print out the workplace sort of graph or longitudinal analysis and show them that these patients indeed are really improving, I think they feel comfortable with them in our care.
I've just got one last question. We have more data, more information on our patients' eyes today than we've ever had. It's becoming exponential. For each of you, what is the value of using that data in your practice, and how has ZEISS Forum supported you in that way?
Yeah, I think a big way that I've used it is for research, actually. So we do a lot of research on retinal thickness fluctuations, amplitude changes, what that means for patients, rather than looking at CST, which is probably the poorest marker for disease activity. And we use that to help us guide the patient. We're using more advanced tools now, and I'm sure we're going to see them embedded in the workplace. But things like amplitude make a big difference with regards to the overall control of a patient. And we've been able to show in our research studies, as well as multi-centered randomized clinical trials, that control of amplitude and fluctuation matters almost as much, if not more, than CST at this point.
Eric?
Yeah, I mean, I think it's certainly useful from a research perspective. I think there's a lot of other, possible uses here. Obviously we're, focusing a lot more on sort of quality or value-based, payments from, government and even commercial payers. And so I think, having access to this data, if you want to, pull up, OCT data, very easy. You have all that data plugged into your retina workplace. And again, you have, at least in our practice, 10, 15 years worth of data, right? So, really a big data sort of set, which is a great way to utilize that. You can also extend that to, just negotiating with payers, right? So you want to say, hey, we think we provide, optimal high quality care, and here's the proof, right? We can say it all we want, but I think at the end of the day, these payers want to see results. And so I think we're able to provide that based on this, again, huge collection of imaging data and metrics that we collect within the retina workplace environment. You can also extend that to sort of local quality improvement projects if we want, as a practice, to assure that we're providing the best care we can. Again, we can kind of look at how our outcomes, and then can we implement changes and can that result in quality improvement. So I think it's another way, aside from research, where this data really is going to impact, our practice, both from a financial and a quality standpoint.
Well, thank you both for this today. Rishi, it's been really nice getting to know you. Eric, I talk to you all the time, but I never actually see you in person, and so it's good to talk to you during all this. It's been an honor, just a pleasure, a privilege to speak with both of you, and thank you for sharing your very valuable insights on developing this total practice workflow that will, for our patients, support enhanced care and a better provider experience. And thank you all of you in the audience who have been listening. Have a great day.